The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
In this episode of the Fast Archives miniseries, we're releasing one of our favorite talks from Rob Bryant. Ketamine is like a movie star in a defamation lawsuit. You know it, you love it, it's been the star of the show for a while, but for brief moments, its reputation gets tarnished by one study or another. Then it's cleared of all charges, ruled as falsely accused, and restored to its original celebrity status. Whether you love it or hate it, ketamine is famous. From its cardiovascular effects to its impact on mental health and long-term bladder issues, Rob will shed light on some lesser-known aspects of this popular medication. Get ready for an eye-opening discussion that might just change how you think about ketamine. We hope you enjoy.
You all will have been exposed to a variety of affection for ketamine for the providers that you interact with. We've got the lovers that believe that ketamine is made from an extract of the milk of lactating angels, and the haters that think that ketamine comes from the seminal vesicles of someone that lives in a place that's a lot warmer. I want to spend most of the time talking about cardiovascular stability, a little bit of time talking about ketamine and depression, and then as your bladders are finishing, we'll finish on bladder issues. It's important to confront and listen to conflicting opinions that are different than your own, because sometimes we're wrong. We don't like being wrong because we're at the top of the medical food chain for the letters after our names, but it's important to at least listen to data that conflicts with your preconceived notions. So we'll start off with cardiovascular implications of ketamine. The gist of ketamine, this is a stylized diagram of a neuromuscular junction. When we give ketamine to a healthy patient, we secrete more neurotransmitters, and then the ketamine helps delay the reuptake of those neurotransmitters. We're earning interest on the neurotransmitters that are already being secreted. If you don't have a lot of money in the bank, you don't make a lot of interest. If there's not a lot of neurotransmitters there's not a lot that you can delay the reuptake of. So a lot of our patients are physiologically bankrupt, and we expose them to the mild myocardial suppressant effects of ketamine without the benefit of delaying the reuptake of nothing. And there's been several case studies and case series of patients that got a full induction dose and then had really bad and life-ending things happen to them. Happens with etomidate, happens with other induction agents, but ketamine's not innocent of that. The workaround, and we talked about this last year, is to resuscitate, intubate, and still anticipate that things can go sideways. There were a couple of case series that came out, a couple of cohort studies that came out in 2020 and 2021 that I want to dig into. And these registry studies are interesting in that they can answer some questions, but they're not perfect. They're not randomized controlled clinical trials. But each of these studies has the same build. So there's a National Emergency Airway Registry, which is basically a collection of 25 really good academic emergency departments where they keep obsessive details of every intubation in terms of who the patient was, why they were intubated, the intubation dose, their vitals, and everything. The weak link is that the people putting in that data are the residents. I was once a resident, and I can vouch for my lack of reliability at filling out forms. So the data for those intubations is ideally filled out immediately after the intubation or at the end of that shift, and not 3 days later, but we deal with the data that's put into these registry studies. So first study, 3 years worth of data looking at ketamine versus etomidate use, specifically looking at the rates of post-intubation hypotension in the setting of sepsis. So 12,000 patients, 531 of whom were septic, 2/3 of them get etomidate, 1/3 of them get ketamine. And we can see across the 25 emergency departments, there were clearly some lovers, and there were clearly some departmental haters of ketamine, where one department miraculously gave no ketamine. Similar to a lot of our departments, because there's now an impending ketamine shortage, which is going to suck. Their endpoint was systolic blood pressure less than 100 millimeters of mercury 15 minutes after the intubation. And first annoying outcome is that ketamine was overrepresented in those that got hypotensive within 15 minutes of intubation. We don't know why the providers chose ketamine. We don't know why they chose etomidate. All we know is that in this registry study, their primary outcome, ketamine failed to clearly be better than etomidate. So the statisticians and the science people that understand math will argue that this data is flawed because it was a registry study, but ketamine certainly didn't knock this one out of the park. Vasopressor use, not surprising, a little more in ketamine than etomidate. The authors appropriately state that the data call into question the widely held belief that ketamine is hemodynamically stable. My workaround for my sick patients is to give a little bit less ketamine and see if that makes them a little bit less sick. And this study didn't look at dosing at all. It was just, did you get ketamine or did you get etomidate? The folks in the Kent, Sussex, Surrey Air Ambulance have looked at this a little bit, and their protocol for if someone looks big sick and it's just an objective, wow, you don't look good, is to dose down on their induction agent. So instead of 3 mics per kilo of fentanyl and 2 milligrams per kilogram of ketamine and 1 milligram per kilogram of rocuronium, they do a 1-to-1-to-1. They found that in patients that were failing the sniff test and looked terrible, that they were able to maintain a degree of hemodynamic stability by dosing down on their ketamine. So next registry study, same data set of patients in that near registry, looks at almost all comers to see what happened with their rates of peri-intubation hypertension. 3-year registry study, similar patients in each set. The reason that I had the asterisks for all comers is that they picked this weird Goldilocks blood pressure zone where you had to have just enough blood pressure, but not too much. So your blood pressure had to be greater than 100 systolic and less than 140 to be able to be entered in. And I don't know what the rationale was for excluding the 150s and the 160s and the 170s, but their rules, not mine. They did look at dosing. Those that received more than 1 milligram per kilogram of ketamine and those that received less than 1 milligram per kilogram of ketamine. Same thing with etomidate, greater than 0.3 per kilo and less than 0.3 per kilo. 20,000 patients, they weed out those that had too much blood pressure. They weed out those that didn't have enough blood pressure, and we're left with 6,800 patients, with the vast majority of them getting etomidate compared to ketamine. This is the same data set that had all of the septic patients in them. Ketamine was more likely to have a systolic blood pressure less than 100 15 minutes out from the intubation, 18.3% versus 12.4%. In patients that were septic, 19% of the ketamine patients got hypotensive compared to 10% of the etomidate patients. Again, same patients that were in that septic data set. Interestingly, the ketamine patients might have been a little bit sicker because when the residents filled out the form of did this patient have high-risk airway features or did you think this was going to be a difficult airway, the ketamine patients were overrepresented. So it's possible that the ketamine patients were sicker, therefore they were more likely to get hypotensive. In trauma patients, there was no difference in rates of post-intubation hypertension comparing the ketamine to the etomidate. And annoyingly, based on what I do with my practice, they weren't able to find a difference in those that got less than 1 per kilo of ketamine compared to those that got more than 1 per kilo of ketamine, which is super annoying when something that I do in practice doesn't line up when they actually study it. I will continue to practice that if my patients are older than their blood pressure or if their shock index is greater than 0.9, I'm going to dose down on my ketamine. The authors in this study have, again, appropriately proposed that we prioritize pre-intubation resuscitation over medication dose and flavor of medication selected. It's as if they're telling us to resuscitate, intubate, and anticipate. They also say that it's prudent that if those patients remain frankly unstable and look terrible despite appropriately resuscitating them, that we try to use the smallest amount of medication possible. Again, registry studies, so the data are flawed. However, if this study had showed that ketamine was the clear winner, we'd all believe it and say, yay, ketamine won. So we have to pick and choose when we apply our science rules. So it at least shows that ketamine isn't the golden child that we thought it was, and we still need to be careful when we're dealing with these big sick patients. As a New Zealander, anyone French in the audience? It brings shame on me as a New Zealander to have to ask the French for help, but I will for you guys. So the only randomized controlled trial comparing ketamine with etomidate is from France. They did a pre-hospital and emergency department study where the intensivists were blinded to the induction agent that was used in the pre-hospital realm or in the emergency department. And the primary outcome was looking at the mean maximum SOFA score during the ICU stay, but they additionally documented their pre-intubation blood pressure and post-intubation blood pressure. So 689 patients. Again, they wanted them to be just sick enough, but not too sick. So anyone that died before they hit the ICU was excluded. Anyone that wasn't in the ICU for 3 days was excluded. So they picked off those patients that were still sick enough to be in an ICU for 72 hours, but well enough to get discharged before that 72 hours. Even numbers, 230 of ketamine, 230 of etomidate. And 16% of these had sepsis as their reason for being intubated. They found no difference in the mean maximum SOFA score, which is reassuring. Again, ketamine didn't hit it out of the park. It was just no worse and no better than etomidate. When we compare the pre-intubation blood pressure and the post-intubation blood pressure, the way math works is that if your post-intubation blood pressure is lower, then the higher the number, the worse it is. So there was no statistically significant difference between etomidate and ketamine when we look at rates of post-intubation hypotension or degree of post-intubation hypotension, which is reassuring. So the only randomized clinical control trial between ketamine and etomidate shows no difference between these two agents, which is reassuring. This term has been coined within the last couple of years, a hemodynamic DSI. We're all, I think, pretty familiar with a delayed sequence intubation being done for someone that cannot pre-oxygenate or that will not pre-oxygenate. Hemodynamic DSI means that we turn the lights off and make sure the lights are out and then paralyze our patient. So we're using the smallest amount of sedative possible so that we're still humanely sedating that patient and then we're paralyzing them rather than giving 0.5 per kilo of ketamine to someone and simultaneously paralyzing them and then torturing them because they're awake during that intubation and we didn't actually get their lights out. So hemodynamic DSI is giving the smallest amount of induction agent possible, making sure the patient's lights are out, and then paralyzing them. So that's ketamine and the cardiovascular effects. We're going to move on to brains, ketamine, and depression. There's been at least theory that ketamine should potentially help with depression. And the way things happen in medicine, we get firstly a couple of case studies, then some case series, and then we study things to see if it actually works. So there's all this hype up front of like, I had this one patient, I did this thing, and something amazing happened, and oh, I had this one patient, and same thing. So you get all these people together with their case series, and then we start studying it. So first review in 2015 said there's early preliminary evidence of reduction in depressive symptoms, which is great. All these patients were awake and depressed and were told, we're going to give you some ketamine or something else, and your depression might get better. Annoyingly, there's no easy way to accurately measure someone's severity of suicidal ideation or their degree of depression. But the best scale is the severity of suicidal ideation score. The study in Tehran looked at giving an infusion of ketamine in the emergency department, and it looks pretty good on this graph that has 10 as the lower score on the graph, with a reduction in their severity of suicidal ideation from an average of 23 down to an average of 13. Annoyingly, to be truly not suicidal, you need a severity of suicidal ideation score less than 4. So they improved things, but it didn't magically make the patients not depressed and not suicidal. But it at least made things less bad for these patients. Why do we care about patients potentially being suicidal? Well, because we're human and we should care. But additionally, in our line of work, sometimes we'll be called to a single occupant motor vehicle collision. When patients survived these single occupant motor vehicle collisions and were asked, hey, is there any chance you were suicidal? The honest ones, up to 1 out of 15 times, said, yeah, actually, I was trying to kill myself when I crashed my car into that light post. But we don't know that when we turn up on scene and see just the patient who's crashed and unresponsive and can't tell me, hey, so you know, my life's awful and this was my suicide attempt. Not surprisingly, those that are young, male, single vehicle, single occupant, no skid marks with alcohol on board with a recent stressor were more likely to be in this group. So if ketamine helps depression in normal patients that just weren't part of a motor vehicle collision, maybe if we intubate them with ketamine, we can offset some of their depression so that after they survive their traumatic injury, their depression can improve. The Cochrane collaboration's job is to rain on everyone's parade. And in 2015, they did just that by saying that there's limited evidence for ketamine's efficacy over placebo. They cleaned things up a little bit, and by 2021, they said ketamine is maybe more efficacious than placebo, which is not exactly a glowing review, but it's a little better than the 2015 data. The challenge we have is that most of the studies are done on awake patients where we're saying, hey, we're going to give you this drug, it might help your depression, we can compare it to something else. We don't know what you're getting, you don't know what you're getting, but tell us. So the patients are awake and they're aware that they're getting something that might help their depression. This meta-analysis out of China looked at patients that were going into hospital, getting a major surgery, who were then going to have a hospital stay. And most people that get surgery don't exactly love the experience, and rates of postoperative depression are known to go up. So while these patients were asleep, they randomized them to ketamine or no ketamine and looked to see whose depression got better or if there was a difference in rates of depression. And annoyingly, greater than 1,000 patients, all of them asleep, not knowing what they were getting, there was no difference in the rates of post-operative depression, which is super annoying for our trauma crew who we're trying to help the potential depression in. So what we know is that in studies where you hold a syringe up in front of someone and say, this might help your depression, ketamine works. But in patients that don't know they're getting ketamine and don't know they're getting something for the depression, it maybe doesn't work. I want to finish on bladders. This is Marvel's new superhero, Bladder Man. And I think we all have that same superpower of being able to hold 300 cc's in our bladder while doing a 3 to 4 hour patient transport without access to bathroom facilities. Ketamine is known to cause interstitial cystitis, which is this weird chronic inflammatory issue that can basically give you constant UTI symptoms without actually having an infected urine. The sweet spot for this, you have to use a lot of ketamine all of the time. So you're going to use ketamine 4 times a week for months and months and months and months and months to actually get ketamine-induced interstitial cystitis. The reason we should be aware of it is that if we're transporting someone that's awake and we're using pain dose ketamine, in addition to planting the dream and say, hey, we're going to give you some medicine for pain that the military uses. It's great. It's going to help your pain. It might make you feel a little floaty and a little weird. By the way, have you ever overused ketamine, or do you have interstitial cystitis? Because this might make your bladder worse. And if they say, yeah, actually, my bladder's awful, I don't abuse ketamine, then maybe just sticking with fentanyl dilaudid or a narcotic approach and not using ketamine is reasonable. If those agents fail and the patient's got a ton of broken everything, then give the pain dose ketamine. But bring up ketamine-induced interstitial cystitis to at least have you pump the brakes on giving pain dose ketamine to blindly and with reckless abandon to everyone. Take-home points. Registry studies show rates of post-intubation hypotension with ketamine are higher than with etomidate. So when you're transporting your next patient that you've intubated and you turn up to one of the ketamine-hating emergency departments, the receiving physicians might say, don't you guys know that ketamine's awful? And you can say, well, because of science and registry studies and flawed statistics, we can't accurately interpret that data, or we know that ketamine is probably not amazingly better than etomidate. And as you know, there's only one randomized control study that shows that's compared ketamine and etomidate, and there was no difference. So that's the best we have. Ketamine did not hit it out of the park when compared with etomidate. It still has utility, because if it's me that's getting intubated and you miss your first 2 airway attempts because of whatever's going on in my throat and you're about to put a knife to my neck 10 minutes after you gave me that ketamine, I'd far rather still be sedated and still have pain control on board than if you gave me etomidate, which is already worn off, so I'm awake during my first cric experience. If your patient's big sick, give a low dose, make sure the lights are out, then paralyze them and still proceed with caution. Resuscitate, intubate, and anticipate. Dumbledore's right. Ketamine is not magic. And if it hurts when you pee, it's probably not the ketamine.
This has been a production of the Flight Bridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.